beginning the session now.
Okay. So right now we have Akash and Amna, seems like. Do we have any more people? Or do we anticipate more people joining in?
Okay, we are live. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along so they can be addressed. I'm honored to introduce our mentor for today, Dr. Khan. Dr. Khan has a private adult nephrology practice in Dallas-Fort Worth metropolitan area. She's affiliated with Baylor Heart Hospital, Medical City Hospital, and Texas Health Resources. She also completed her fellowship training at Henry Ford Hospital, Wayne State University, Michigan. And now it is my honor to request Dr. Khan to begin today's session. Thank you.
Hey guys, hello everyone. I am Dr. Sharper Khan. I'm a nephrologist by profession and currently practicing nephrology in Dallas, Fort Worth, I would say Dallas area primarily. So let me start off just by giving you a little bit, about myself. Let's see if I'm able to. So basic topic that I would touch base on, briefly cover would be renal physiology, which seems to be a bit complicated, but if we break it down in a simpler way, it gets very simple and easy to understand. I think this was one of my favorite topics, even in med school, so I kind of have a good grip on the subject now since I practice it, so I think I should be able to break it down in a simple way. All right, so yeah, welcome guys. I think you're already, all of you are muted. And if you have any questions during the whole talk, you can just, type it in the chat box and I would be able to take your questions at the end of the presentation. So let's start off how my career started, right? I mean, we all start at some point thinking about what direction to go, what stuff to do. I did my med school in Pakistan. My husband, who was with me in med school, I married him. We moved to the U.S., which is our traditional way. I guess we all strive to, build up our careers, and that's what we decided to do. We took our steps. Then I primarily opted for internal medicine. My husband always had an inclination for pathology. Being from a pathology background, we started off with our hands-on experience, shadowing, observerships, of course, research, because as we go along, I guess it's becoming more and more important how to, get into good residency programs with more hands-on experience. So shadowing, again, essential because if we come in from, if you're foreign grads and if you're coming from other countries, of course, we need to understand how the system works in the United States. So we began our careers. I got into residency program in Michigan, and my husband got into his pathology residency in Ohio. So we kind of started our careers in different states, which was kind of a struggle, which was kind of a challenge, but we were able to manage it. I had my child during my intern year, again, another challenge. So, but we were able to, finish up our residencies. We got back together. We did our fellowships. My husband did his pathology fellowship at UTMB in Galveston, while I started working with a private in a private setup. So moved to Texas from Michigan, and now currently living in Frisco, in Texas, and practicing in Plano. So typically what happens with a foreign grad, of course, things are different here. For US grads, I mean, we have 5 years of med school. I did it at Rawalpindi Medical College in Pakistan, 3 years of internal medicine residency. Of course, that ranges from anywhere from 3 to 5 years. I did it at Wayne State University in Detroit, Michigan, and then spent 2 years in nephrology training at Henry Ford Hospital in Detroit. And since then, pretty much practicing adult nephrology in a private setup since 2005. My initial training, my residency training was at Sinai Grace Hospital, which is part of DMC at Wayne State University. And this was a good experience because being from, doing it at Sinai Grace in the very heart of Detroit, the patient population we got to treat and see, it was very intense. I saw a lot of pathology. I saw a lot of disease prevalent in that particular indigenous population in Detroit. So that actually gave me a boost right from the get-go, where we can see and handle a lot of, I would say, complicated diseases. This is Henry Ford Health System. This is the whole old campus, I guess. My fellowship training here was tremendous. Again, we got to see a lot of disease. We got to manage a lot of renal disease, primarily, because diabetes, you name it, right? A lot of glomerulonephritis, a lot of other pathologies. We got to see a lot in the population we dealt with. So just a little background, this was my nephrology division at Henry Ford. I have very close association. Initially, I think back in 1925-26, this was actually Clara Ford School of Nursing. Ran successfully for 71 years, and then was converted to the admin side, and a lot of departments actually came in. So historic building, it's a beautiful building. We had a nephrology department at the fourth floor, so there's some association there. Okay, so what made me move? Primarily from Michigan, added to Texas. So I can't say enough and stress enough on the fact that snow was the key factor. Alrighty, so let's look at the hierarchy. You start off as a medical student, then comes your resident, a residency, which is intern year, junior resident, senior resident, anywhere from 3 to 5 years, maybe longer, depending on the path you choose. Comes the fellowship, again, typically 2 to 3 years. If it's a research track, for nephrology, it's about 3 years. I did the conventional track, which is 2 years of fellowship. And then you become the attending, either in a private setup or you become, part of an academic institute. So, general belief, nephrology, the popularity of nephrology over the years has gone down. I guess there have been some factors involved why, people or med students choose or residents choose not to go for nephrology. I guess the most difficult physiology might be one of the reasons, so it probably is considered a bit complicated. Challenges of the patient population, of course, the demographics or the patients that we deal with, end-stage renal disease, chronic kidney disease patients, they're considered more complicated as compared to, patients probably with different disease processes, because this is more like longitudinal care, more long-term care, with complicated factors associated with end-stage kidney disease or chronic kidney disease. Less advancements, maybe dialysis, hemodialysis started off maybe close to about a decade ago. About 1945-46, I think, is when the first successful hemodialysis happened. It's almost not a decade, my bad, about a century ago rather. So, but since then, dialysis has advanced in many ways. But of course, and now artificial kidneys on the way. So probably one of the reasons is less advancements. In my opinion, it's not. Low monetary compensation, well, that's another factor. It's probably a key decision maker for many residents. And insufficient procedures. People love to do procedures. Of course, in nephrology, we don't really get to do a whole lot of procedures. My forte, I guess, I like complicated physiology. I guess it's simple enough if you understand the basic concept of nephrology, starting from renal physiology. Once you have a good grip on the subject, which I always had, and that's why, my inclination, then you can understand the pathology, you can understand the mechanisms, how it's all working. It's all very, very, very meticulous. It's all very mathematical. And, once you figure it out, There's no way you forget about it. For me, longitudinal care is more important. I guess if I start off with a patient who has maybe, some mild degree of chronic kidney disease or maybe some acute problems, and then we establish care with those patients and they go along with you for many, many years, until, of course, if they become end-stage renal disease or their kidney function doesn't progress, whatever the reason is. I guess you have to have that long-term relationship with those patients, and that's key for me. It's constant analytical thinking. You constantly, this becomes a second nature. So, I mean, you're doing your math in your brain all the time, right? You see acidosis, you see alkalemia, you see any electrolyte acid-base disorders, hyponatremias, high sodiums, low sodiums, what's happening at what level, what receptor is working in the tubule where. So that becomes part and parcel of how you think, and that gives me a constant motivation. For nephrology, I guess I can safely say it's good work-life balance. If it's a right setting, of course. I mean, we have to have at a certain stage in life, when you have your family, you have kids, you have to have that balance. Regardless of having kids or not, I would say, whatever situation or life stage you're at, I guess it gives you a good work-life balance, and that's important for me. I think that's important for everyone. I'm a no procedure person, so I don't mind doing no procedures. I'm happy with the way I do or practice my specialty. So for me, I think nephrology was the right choice. So what we deal with when we deal with general nephrology diseases, right? As part of my practice, what I normally typically see, of course, for the most part of my practice or the chunk of my practice is chronic kidney disease. Disease is prevalent all over the globe, I would say now. Hypertension, diabetes, metabolic syndrome. So we get to see a lot of chronic kidney disease, right? I mean, and then the GFR and how the GFR and the staging of kidney disease works and all. We can get into those details later, maybe. But that's the part, essential chunk of our disease population. Of course, we do get to see a lot of acute kidney injuries, especially in a hospital setup. We normally get consults, including critical care consults for acute kidney injuries. It can be any type of acute kidney injury due to any particular reason. And that acute kidney injury actually makes us get involved in a lot of critical care nephrology, which includes, more modalities like continuous renal replacement therapies, CRRTs, SLEDs, etc. We do get to see a lot of nephrolithiasis. Of course, that's another prevalence due to the average American diet. You get to see a lot of kidney stones. Management of kidney stones, it's actually pretty satisfying. If you're able to make someone get rid of the kidney stones, that's our achievement right there, because it's a nuisance to have kidney stones. Hypertension, primarily, that's being managed for the most part by nephrologists, many other specialties, but yeah, that's a nephrologist forte as well. Hyponatremias, that's an essential part of our practice as well. We get to see a lot of hyponatremias primarily, again, due to various reasons, acid-base disorders, patients in ICUs, having all sorts of respiratory problems, and then metabolic compensations, and we do the math and we kind of figure out. That's always challenging. It's fun. Hyperuricemia, that's part of renal disease process as well, so that's part of our management as well. End-stage renal disease, again, that's another big part of our practice. We manage end-stage kidney disease, either with dialysis, different forms of dialysis, hemodialysis, peritoneal dialysis, and then, of course, kidney transplant, which gets done once they're end stage and they happen to have their kidneys. And post-kidney transplant is another tedious management, but then, again, that's the fun part. You get to see, as part of your practice, kidney transplant patients and manage their post-kidney status. So topics I would probably cover today and touch base a little bit, is the organization of the kidneys, starting at a simple level. What's the glomerular physiology, how we calculate filtration fraction, reabsorption, secretion at the tubular level, regulation of blood pressure, again, how it gets done, just a basic idea. I would just probably lightly touch on that subject as well. Acid-base balance, where the receptors are, how it gets done, hormonal regulation of the kidneys, and maybe some clinical relevance, I guess, throughout my presentation, I guess I'll just drop in a question. You can feel free to just, answer in the window chat, or we can always go back and do it at the end of the presentation. So organization of the kidneys, this is how the kidneys look like. Right kidney, your left kidney, with the renal glands on top. This is the renal vein, renal arteries, renal vein right here, renal artery. And then once we go into the details of it, how the arteries get broken down into arterioles and venules, and we'll talk about it. That's how it looks like. We have two kidneys, right being a little lower. Can anyone type in the window why the right kidney is a little lower? I'm not sure exactly if there are any high school students, but yeah, that probably would be a good question for them. So right kidney is a little lower than the left one, mainly because of the liver on the right side, and that kind of, oh yeah, I gave my answer, and there's a chat window, someone's there. Yes, sir, absolutely. Elish Bazayed, presence of the because of the presence of liver. Absolutely, you're right, because of liver, Beanish. Yes, girls, you are right. So let's see. Let's go to the next one. So functional unit of the kidneys. Nephrons. Can anyone guess how many nephrons we have in each kidney? Again, that's a very simple, basic question. So we have someone, oh yes, millions. So each kidney has about million nephrons. Absolutely, guys. That's correct. So kidney is working constantly. So many nephrons in there, and we'll talk about how these nephrons work and what happens at the molecular level. So there are two types of nephrons there. That's for the cortical nephrons, that's the majority of nephrons in the kidney. If you layer the kidney, right? So the first top portion is the cortex, and the lower part is the medulla. That's the inner medulla right there, inner stripe of the outer medulla. Two types of nephrons, primarily the cortical nephrons, which are essentially in the cortex, and then the juxtamedullary nephrons, which basically their main absorption part, which is the loop of Henle, is in the medullary part of it. So I will come to what the importance is of these two nephrons in a bit. So that's how the functional unit looks like. This is the glomerulus, and I'll tell you what glomerulus is. I mean, it's just basically a tuft of capillaries. And this is mainly the tubular part of the nephron, proximal convoluted tubule. This is the loop of Henle. This is the distal convoluted tubule, collecting duct later on, and then it becomes part of the ureter. So another question, guys. I already gave you the answer. Okay, which nephron gets more affected with acute tubular injury? So let's say some patient, having sepsis, hypotensive, blood pressure is low. Patient developed acute tubular injury or acute tubular necrosis, ATN. So which nephron would be more affected? All right, so proximal tubule, it's a good answer. I'm asking particularly which nephron, in reference to my previous slide, is it the cortical nephron or the juxtaglomerular nephron? So let me go back to my slide. Let's see if I can do it. Yes, ma'am. So juxtamedullary nephrons are the ones which are down in the medulla more. Cortical nephrons are more in the cortex. My question primarily is which one probably would be more affected. That's juxtaglomerular is Beanish's answer. Okay, let's see why. Beanish, your answer is absolutely right, and let me give you the reason why. The reason being this. Loop of Henle. Medulla has capillary loops surrounding the loops of Henle, known as the vasa recta. There is slow flow of blood through vasa recta. So that's why the PO2, partial pressure of oxygen in the medulla, is low. So of course, if there's any ischemic damage, the medulla part of it would be more susceptible to injury. So that's a good answer. Now tell me another question. What part of nephron is hyperosmotic versus isoosmotic? That's more towards the tubulary part of this question is more about the tubular part of the nephron. Well, we'll come to that. I guess it's part of my next slide. Alrighty, so let's talk and look at the nephrons per se now. So these are our two nephrons. How it works is basically we have the efferent arterioles, which blood gets applied to the glomerulus through the efferent end of the arteriole. And this is the efferent arteriolar end. Blood gets out of the glomerulus and gets into the pericardium. So basically what happens is in the cortical part of the nephron, if it's a cortical nephron, capillary loops surrounding the distal convoluted tubule, they are called peritubular capillaries, whereas capillaries surrounding the juxtamedullary part of the nephrons, they're called vasa recta. These are the little arcuate arteries. They become interlobular arteries, eventually efferent arterioles, capillary loop. This is the glomerulus. Then it becomes the efferent arterioles, interlobar venules. I think that's how it works, and eventually becomes part of the renal wing. All right, so structural and functional connection. As blood enters to the efferent arteriole, it goes into the glomerulus and gets out through the efferent arteriole. I have that probably would be another question. So I will ask you guys, there are three basic steps or four basic steps happening within the nephron. What would be the first step? Any ideas? When the blood gets into the glomerulus, this is the Bowman's capsule, where it kind of blood enters into the Bowman's capsule, or let me rephrase it, plasma enters into the Bowman's capsule. So what is step one? What's happening here? Do you guys have any idea? I have some answers. Yes, Elishba, it's filtration. Perfect. That's a great answer. So Elishba's been on it. So let's see. So step one is filtration. What other essential functions a nephron performs? Any other guesses? What's happening at step two? Yes, Bean Ishaloshba, you guys are on it. You're on a roll. So what's step two? What's happening in step two? At step two, reabsorption. Perfect. So that's an essential part of the physiology and renal physiology. Filtration is happening. Of course, the blood or the plasma needs to filter out. That's how urine is made. That's how electrolytes are being excreted. Now, why is reabsorption an essential part of the whole physiology? Well, a lot of, I would say, essential elements, they get filtered out, and those need to be reabsorbed in order to maintain our normal function of life, right? Homeostasis and everything. And those essential electrolytes primarily are sodium, glucose, amino acids. We need to kind of reabsorb that. A lot of it has come out and filtered out, but that essentially needs to be filtered or reabsorbed back into the circulation because that's needed for us. What would be the next step? What's step three? That's secretion. Perfect. Perfect. So secretion, why do we need secretion? Secretion again becomes important because some of the stuff, some of the waste products that we do not need in our body, maybe being, produced in an excessive amount, we need to get rid of it, such as waste products such as ammonia. waste products such as hydrogen any form of acids, pyruvic acid, lactic acid. We need to dump maybe urea or maybe, potassium. If potassium is being filtered out and getting reabsorbed, or the body has a lot of potassium load that needs to be wasted out. So secretion becomes important at this point. So these are the essential processes happening at the nephron level. And of course, once this all happens, then we excrete urine, and that excretion or excretory, we dump out urine that has essentially probably what in a normal person with normal kidney function, everything that we do not need in our body is excreted out. Good, excellent. All right, so now a little formula: urinary excretions, basically your filtration minus reabsorption, what gets back into the body, plus your secretion. So that's essentially the urinary excretion. Okay, about renal perfusion. So can anyone guess what a normal cardiac output is? I gave my answer wrong. I asked you a question and give my answer, so I probably need to wait for a little bit until you guys answer. So it's about 4.5 liters to 5 liters per minute. That's the normal cardiac output. That's what the cardiac, basically the heart is pumping out each minute. Can anyone guess how much or what percentage of this cardiac output the kidney gets, which is the renal blood flow? Any guesses? That's excellent, Sadia. It's about 20-25%. Okay, so normal renal blood flow is about 1.1 liter per minute, which is, if you do the math, it's about 20-25%. So what percent of cardiac output do kidneys receive? That's about 25%. So tell me what happens to the remaining cardiac output. So kidney is getting to about 25%. So the remaining part of cardiac output actually goes to other parts of the body. And if it's essentially there are about 1 million nephrons in the kidneys, right? So this remaining 80% would eventually come back to the kidneys for clearance. Alrighty, very good. Okay, that is the next question. All right, I gave my answer before. Okay, I've been clicking too much. So what change tends to increase peritubular capillary fluid reabsorption? That is essential. That becomes your most key renal physiology questions for step 1. I gave the answer out, so can anyone explain why increased efferent arteriolar resistance cause increase in capillary fluid reabsorption? What do you think the mechanism is? So efferent arteriole is right here. If the resistance increases right here, why is peritubular capillary fluid being reabsorbed here more? Because of the constriction at this end, there's more flow at the back end, and that's how your hydrostatic pressure kind of increases, and that's where our starting forces come into play. And more hydrostatic pressure, more fluid gets into the filter. It gets filtered out and gets into the nephron. So every time I have to click back on it. All right. Key elements and key points, I guess, and again, very important for step 1 is your efferent arteriolar constriction. Efferent arteriolar constriction, what drugs can cause, the constrictions, and what effects do they have on the circulation. Important in terms of many processes involved with these hormones and the drugs associated, and why, and they can ask you many questions on non-steroidals and their effects on the kidneys, and ACEs and ARBs on the kidneys as well. So We'll come back to this slide later once I explain to you how angiotensin 2 receptors work and what affects angiotensin receptor blockers and ACE inhibitors on the vessels basically. All right, some more questions, guys. So what effect does a high angiotensin 2 concentration have? That's a very, very important question. What effect does high angiotensin concentration have on glomerular hydrostatic pressure? So let's talk a little bit about these pressures, right? So they're starting forces. There are pressures inside the vessels which can either promote push fluid out or actually pull fluid back in, right? So what would be the two essential pressures? That's the hydrostatic pressure and oncotic pressure within the vessels. So hydrostatic pressure typically is the pusher, right? It pushes fluid out of the blood vessels. Oncotic pressure, which primarily is the pressure produced due to albumin in the blood in the vessels, or oncotic pressure due to proteins in the vessels, pulls fluid in. That's what the mechanism is primarily. That's what's happening at this level. So this is glomerular, well, a glomerulus where the blood is. This is the Bowman's capsule where the blood or the plasma has to be filtered out. What's promoting filtration is what's important here, right? Now, this blood or this plasma or blood getting into the glomerulus, it's basically there are 3 or 4 elements within the blood which basically constitutes blood, right? There are blood cells, there are red blood cells, there are platelets, white blood cells in this blood. There are proteins which are in the form of albumin or globulins, primarily albumin within the blood, and of course then there's plasma. So here the oncotic pressure, because of having albumin in it, is high. And what forces this to come out, and we'll talk about it, is having high hydrostatic pressure, which is kind of pushing as compared to the hydrostatic pressure in your Bowman's capsule, which kind of promotes filtration. So what effect does high angiotensin 2 concentration on glomerular hydrostatic pressure? Let's see if we have any answers. So increase in your hydrostatic pressure and angiotensin, and we'll come to that, what angiotensin does to the efferent arterioles. It basically constricts it, right? So if it's being constricted, again, we have increased glomerular hydrostatic pressure at the back end, and that promotes increase in GFR. More hydrostatic pressure, more fluid gets pushed out, right, and filtered out. What effect would non-steroidal anti-inflammatory drugs have on glomerular hydrostatic pressure? Let's see. What do you guys think? So I show you a slide briefly in my previous slide. Where do NSAIDs work? So non-steroidal drugs being bad for the kidneys, causing what problem, and how is it affecting the kidneys? So Beanish is okay, perfect. So Elishba, you're right. Efferent arterioles is where non-steroidal anti-inflammatory drugs affect, and that decreases your glomerular hydrostatic pressure, right? Because there is efferent arterial constriction, less blood is going in, and of course that decreases your hydrostatic pressure, that decreases eventually the GFR. So that's the right answer. Good job on that. So what effect, that's my last question, and basically I've already given you the answer already. What effect would ACEs or ARBs have on glomerular hydrostatic pressure? So what effect would ACE inhibitors or ARBs have on this end? I already told you what angiotensin 2 does. So what would be the effect of ACEs and ARBs here? So if angiotensin 2 is causing constriction at the efferent end. ACEs and ARBs basically are antagonizing or having an opposing effect on this, would increase your efferent arteriolar constriction, right? So that effect of angiotensin II is being minimized. So you'd have more dilation at the efferent arteriolar end. If you have dilation here, what's happening here? Your hydrostatic pressure is going to decrease. So basically, it's going to decrease GFR, and that's what the preventive or the mechanism of ACEs and ARBs is in basically supporting the kidneys and the GFR, and I'll come to that in a bit. So the next step, or the next Alrighty, another question, and that's a simple one. And I don't know if you are familiar. We talked about all the glomerular hydrostatic pressures and the glomerular oncotic pressures and what the effects are, pushing and pulling, right? So this is a simple question. Let's see, if you have any basic idea of how this works. So let's see, a 56-year-old patient with past medical history of hypertension and diabetes gets admitted to the hospital with septic shock compressors. Glomerular hydrostatic pressure is about 30 millimeter of mercury. Glomerular oncotic pressure is about 25. Capsular hydrostatic pressure, which is the Bowman's capsule, hydrostatic pressure is 15. So what is your net filtration pressure? Any ideas? I know this is a mathematical question. You might have to put in a formula, and we'll talk about that formula in a bit. So let's see, what do we think about this? All right, Mohammed. So, I mean, you can type in how you calculated this 20. I mean, I'm not gonna ask particular details, but yeah, what do you think is happening here? So we have about the glomerular. So this is your net filtration pressure, right? What's happening is we have glomerular blood hydrostatic pressure. In a typical person, it's about 60. It tries to pull out, right? Push out. Then how about having capillary oncotic pressure? So the formula basically is, and I don't know how to write it down, but the formula is net filtration pressure is a sum of your glomerular blood hydrostatic pressure plus capillary oncotic pressure. Both of them would promote pushing the fluid out, minus it's the glomerular oncotic pressure plus your capillary hydrostatic pressure. So some of that minus the sum of the initial one gives you your net filtration pressure. And I don't know how to kind of draw on this slide, but I could have written the formula down. So if we calculate, based on this calculation, if we calculate our net filtration pressure in this particular scenario, it's minus 10. So this is your hydrostatic pressure. They did not give any capillary oncotic pressure, so we consider it being 0. And they did give us these two pressures, so if you do the math, it's minus 10. Now, with this minus 10, which is a negative pressure, what's happening here? No filtration is happening, right? And what leads to this problem? I mean, what eventually would be a problem related to this equation down here? And I keep going back. Let me see. So if no filtration is happening here, this patient is already in septic shock, right? Maybe on pressors, maybe severely volume depleted. So what effect would it eventually have on the kidneys? Any guesses? Where there's no filtration happening, tubule or the capillary tubule is not getting the juice. What's happening here? The tubule is not going to get blood, and ischemic injury can ensue, and eventually ATN can ensue. That's correct, Beanish. Eventually, ATN, acute tubular necrosis, perfect, would lead eventually to uremia. Very good, excellent. All right, so a little bit about GFR and renal plasma flow. So we already talked about what renal blood flow, how much renal blood flow we get as part of the cardiac output. It's about 25%. GFR we measure based on how much renal plasma is flowing through the tubule, right? So renal blood doesn't get into the filtration. It's the plasma, primarily the plasma, excluding red blood cells, excluding the white blood cells, platelets, excluding proteins. The normal kidney does not filter out proteins. The fenestrations in your Bowman's capsule in the glomerular basement membrane, my bad, is they are so tiny, it doesn't allow those big protein particles to pass through. So no proteins passes through, and that's why primarily the stuff which passes through the kidney glomerulus is your renal plasma. And it's, again, another reason primarily why the proteins can't get through is the charge on your glomerular basement membrane and the charge on the protein particles, both negative. So that negative doesn't allow. So that bans the entry of proteins into the Bowman's capsule. GFR normal is about 120 mLs per minute. Ideal substance to measure GFR is inulin, which is filtered, freely filtered, but it's not reabsorbed or secreted. That's ideal if you measure inulin. Normal, and for practical purposes, creatinine clearance is what we use in general normally to measure GFR. So creatinine is an endogenous chemical which gets produced in the body. It filters out, there's no reabsorption, but some of the creatinine does get secreted back into the urine. So with creatinine clearance, GFR is about 10% overestimation of GFR with the use of creatinine. Now, what renal plasma flow is, of course, we know our cardiac output is 4.55 liters, right? Renal blood flow is 25% of that. So if we do the math, plasma, so what percentage of plasma is part of your renal blood or blood flow? What is plasma? What is the concentration or percentage of plasma in blood? Can anyone make a guess? All right, so Mohammed, you said 5%. Do you think 5% of the whole blood is plasma? So let me tell you this. So it's about 50-50. So it's 55%. 55% is our answer here. 55% of the renal blood flow is, or blood is plasma. The rest of it is your cells and stuff. So plasma is 55% of total blood volume. Renal plasma flow, if you do your math, it turns out to be about 600 mLs per minute. Normally, renal plasma flow is measured by PAH. That's PAH clearance, which kind of, lets us measure renal plasma flow. PAH gets filtered out. It is secreted, but not reabsorbed. So pH underestimates a renal plasma flow by about 10%. That's just general knowledge. I mean, these questions can be asked for your step ones. They can actually ask you to measure renal plasma flow. They can throw in some formulas and ask you to, they can give you cardiac output, someone's renal blood flow, and make you calculate the renal plasma flow. So creatinine is normally typically used for, it's an endogenous solute. Now becoming more common is cystatin C, which is another endogenous marker. So in someone, let's say, creatinine is high due to some patient being high, more muscular, and we cannot clearly calculate creatinine, or there are some other variables affecting the creatinine level, then we come to cystatin C calculation. Alrighty, so another slide just to go through the same stuff we had talked about. Renal plasma blood flow is basically your renal plasma flow divided by 1 minus hematocrit, and that's the filtration fraction. Sometimes they can ask you questions on filtration fraction, how to measure filtration fraction, easy formula. That's the GFR divided by renal plasma flow. We already know based on our previous slide what GFR is, typically about 120. What renal plasma flow is about 600. So you do the math, it comes out to be about 20%. So that is the filtration fraction, right? What happens to the remaining 80%? We already talked about it. 80% becomes part of the peritubular capillaries, goes back into the circulation. And depending on how the body senses, what kind of secretion and reabsorption is happening, this 80% gets back into the circulation. More secretion can happen, more reabsorption can happen depending on the constituents of the blood. Okay, let's talk about the tubules. Very essential. I'm just going to touch base. I'm just going to throw some little light on every part of the tubules, and just to kind of let you know how tubules work. If we go into the details, it can take forever to talk about all this. But starting from the nephron level, right, when the filtrate enters into the first part of the tubule, that's the proximal convoluted tubule. There are certain receptors, there's stuff starts to happen right there, and then some important steps happen at the proximal convoluted part, and we can talk about it. So here, 2/3 of sodium, about water, potassium, chloride reabsorption happens. So that is an essential part of the nephron where majority of reabsorption is happening, right? And sodium reabsorption is coupled to the transport of glucose, which is basically getting reabsorbed as a secondary mechanism. So primarily sodium absorption is key element here. The rest of it is just secondary absorption. There are pumps on this, in the tubes, on the basolateral part, on the apical part of the membranes, right? So this is your sodium potassium ATPase. That's an essential molecule here, which it's basically what happens is its primary active transport happens here. Due to this pump, of course, there are secondary active absorptions or transportations happening at this level. Important receptors are present here. They perceive, again, based on your molecular concentration in the body, absorption is happening at this level. Fanconi syndrome, essential in step 1. I think they can ask you questions, or on step 1, step 2, I think even later on for your boards. This is an important syndrome. They can ask you questions. Fanconi syndrome happens at this level. There are receptor problems, either genetic or acquired problems happening here, which can affect absorption of many electrolytes, including potassium, including phosphorus, sodium, and primarily your chloride. So, all right. Another importance is the SGLT2 inhibitors, and I'll come to that in a bit. Now, sympathetic nervous system, if it gets activated, it upregulates your sodium potassium ATPase, so more absorption can happen with sympathetic overactivity. So sympathetic nervous system activates, it increases reabsorption of sodium primarily. Filtrate at the end of proximal convoluted tubule is isoosmotic. So basically the amount of reabsorption happening here, it doesn't really changes the osmolarity across the membrane. So at the end, towards the end of this proximal convoluted tubule, the filtrate is essentially isoosmotic, having the same amount of osmoles as the blood. SGLT2 inhibitors, very important, becoming very important now in managing diabetic kidney disease. And what it does is basically this is where it kind of acts on, right? So it decreases glucose reabsorption, decreases serum glucose levels, and that's how it promotes glucosuria. So basically what it does is it actually dumps out glucose. It binds to the receptor here, inhibits the receptor, and glucose, instead of getting reabsorbed, gets dumped out in the urine. It gets dumped out in the urine. Another question which might happen, which they might ask you is, like, since this drug is becoming more common now, why does it cause, or why does it increases the chances of having urinary tract infection? So any questions for my step 1 takers, step 2 takers? Why does SGLT2 inhibitor, Jardiance, Farxiga, you might have heard about these drugs. So because of more glucose in urine, absolutely, Venus, you're right, Sadia. It increases glucose in the urine. High glucose, sugary urine attracts more bacteria, and that's how the propensity to UTIs increases. Excellent, excellent. Carbonic anhydrase inhibitors, it's a class of diuretics. Again, they act mainly at this level, and that they can ask you questions on that as well. Acetazolamide, essential drug. It's a diuretic and can act at proximal convoluted tubule part. All right, let's come to the next one. Thick ascending limb. So we have the descending limb of the loop of nephron. I don't have the slide, but yeah, you can just recall the previous diagram. So there's a thick descending limb, there's a thin ascending limb, and a thick ascending limb. So it kind of loops around, right? Descending limb, what is the importance? We have the NKCC2 receptors. Again, this is sodium receptor, this is chloride and potassium, and they all are being reabsorbed, right? Again, primarily, this is sodium potassium ATPase, primary reabsorption, right? So, and this is secondary active transport happening at this level. There are intercellular areas where magnesium and calcium reabsorption can occur based on the osmolarity of the fluid. Potassium receptors up here, again, it's permeable to water. Important key factor. Maybe they can ask you questions on the physiology here. Ascending limb is impermeable to solutes, permeable to solutes, impermeable to water. So as we go along the loop, the descending limb is permeable to water. Water can get reabsorbed, but as you go along, then the permeability to water kind of decreases, and basically none. All right, so our loop diuretics, common ones, furosemide, bumetanide, torsemide, they act at this particular level. So what can be one of the side effects of loop diuretics? So furosemide is basically what we use for patients who have significant volume overload. We want to make them get rid of water, right? So they actually act at this level, and they prevent reabsorption of sodium, and water basically gets, the reabsorption of sodium gets halted, and that's how you dump water out, and water goes along with your sodium down the stream, so you get rid of the fluids. This is the distal convoluted tubule. It's impermeable to water, but there are so many receptors right here. There are some important ones. This NCC, I think it's a co-transporter. There are calcium receptors here, the PTH receptor, so calcium absorption gets affected through the PTH receptor activation or inhibition at this level. Lowest osmolarity. Again, important question, lowest osmolarity in the distal convoluted tubule, because here active reabsorption is happening. Thiazide diuretics mainly affect this receptor up here. So this is your co-transporter. PTH receptor increases calcium absorption. If it gets activated, PTH gets secreted more out of the parathyroid gland. It basically acts on this receptor. Calcium gets reabsorbed, and vice versa. So the ion transport in collecting tubule. So this is the lost part, very lost part of the kidney tubule. Very important is the ENaC channel here. And of course, you still have on the basolateral side your sodium potassium pump and your intercalates. So two important cells at this level are the principal cells, primarily involved in your potassium and sodium, and then the intercalated cells, which are your basic cells for acid-base balance. So principal cell, mainly involved with aldosterone, antidiuretic hormone. There are aquaporins, and all these cells they have, or the receptors have different mechanisms. They work at the different limbs, and we'll talk about that in a minute. Intercalated cells are your acid managing cells. Now, spironolactone, one of the aldosterone antagonists, spironolactone works at this level. Aldosterone upregulates hydrogen ions. ATPase is in the intercalated cells. So, I mean, that's just the extra stuff that I wanted to mention. Water transport in collecting tubules. Okay, so let's talk about the luminal and the basolateral membranes of the collecting duct cells, right? So water permeability is essential, or becomes essential in response to your aquaporins, in response to the V2 receptors. So what are V2 receptors? Can anyone guess what V2 receptors are and what would their mechanism be in relation to water? So there's a hormone in the body, gets produced by the pituitary, antidiuretic hormone. What would it do? Any guesses? ADH acts on V2 receptors. Awesome. That's correct. So how would it affect the V2 receptors? Let's say someone has high secretion of ADH. So what would happen to the whole mechanism? High antidiuretic hormone. Yes, Freddie. Stimulates GCPR signals. Increases water reabsorption. Excellent. So aquaporins gets incorporated due to this effect, and that increases water reabsorption. And increases water permeability. All right. And this becomes really important when we are talking about these medications, aquaporins, and V2 receptor agonists and antagonists in management of hyponatremia. Another question that they can potentially ask you is, what is the precursor for ADH? And that's an amino acid called arginine. More aquaporins, more water reabsorption. So I'll just summarize. I briefly touched about, the different parts of the tubules, renin-angiotensin system. Again, very important physiology. And if you understand the physiology and at what level these mechanisms or these drugs and their receptors and then the blockers in terms of medications is happening, that would be very important for you to learn as part of physiology. And they can ask you multiple questions on the renin-angiotensin system. So renin gets released from the kidneys, right? So it's one of the hormones which gets released from the kidney in response to various factors, especially a drop in blood pressure, drop in fluid volume. Renin gets out of the kidneys. Now, liver produces angiotensinogen. Renin acts on it and converts into angiotensin 1. All right, and then comes the lungs. ACE, your angiotensin converting enzyme, gets into play here and converts angiotensin 1 to angiotensin 2. What does angiotensin 2 do? We already know that. We already went over it in our previous slides. Angiotensin 2 also acts directly on blood vessels, stimulates constriction. What does ACE or ARB do? Prevents this step. So this would be an important slide in determining what drugs would cause what and at what level. So angiotensin 2 also acts on adrenal glands to stimulate the release of aldosterone. Aldosterone, and as a result, acts on the kidneys and stimulate reabsorption of salt and water. Okay, well, someone who is volume overloaded, what do we need to do in order to prevent this step? Right, so let's talk a little bit about our medications. Your direct renin inhibitors. So it's a class of drugs, eliskerin, that acts on this particular part of the step. to prevent renin release from the kidneys. Important step if we are trying to decrease renin production. ACE inhibitors, they primarily prevent, they block and they prevent the formation of angiotensin 1, a conversion of angiotensin 1 to angiotensin 2 is primarily where they act on. ARB is a blocker, so it's a receptor blocker which actually acts on your angiotensin 2 and prevents further production of aldosterone. But you also have your aldosterone antagonist, so there are so many medications, so many steps which you can use in order to prevent these steps from happening. Aldosterone antagonist primarily acts on your aldosterone receptors. It antagonizes it, doesn't let aldosterone work on it. So that's how it kind of works here. ACEs and ARBs, important drugs in renal physiology, in preventing renal damage, in preventing or protecting kidneys, is by their effect on the efferent arterioles. Very important, it dilates it decreases GFR, it decreases the workload of the kidneys, and that's how it kind of works and prevents and supports or protects the kidney. It decreases the workload of the kidney. So that is important, guys. I guess that's some simple basic questions. I hope you're able to understand the basic steps, and if you understand the basic physiology of it all, it's easy to actually pinpoint where the problem is happening and how to control it with these medications. And that's what they like to ask a lot in renal physiology questions. So that's all about, briefly about the renal physiology. If you have any questions, guys, feel free to ask me. I know this is primarily about my career path, but I wanted to touch base, on the basic concept of kidney. So I would take any questions. You all did a good job. Great job, guys. So, I mean, if we understand this, I guess part of, the process is done. You would understand pathology more than anything. Of course, there are different elements. That's glomerulonephritis, that's molecular level, injury at molecular level happening, what type of injury leading to what kind of gene, what is nephritic. So all this is essential. But renal physiology becomes the key factor in maintaining homeostasis in the entire body. So questions, please, guys. If you have any questions regarding why nephrology, what else you want to know about nephrology, and if you shadow, let's say if you're in clinic with me, of course, this is what you deal with for the most part.
Hello.
Oh, hey, Freddie.
Hi. Thank you for your lectures and your mentorship, Dr. Khan.
You're very welcome.
We will now begin our Q&A session. My name is
Absolutely.
Freddie Flores, and I am a student at the University of Maryland, College Park. I am a pre-med and biology major.
Mm-hmm.
So with much interest, I would ask our first question for the day. So who is more at risk for developing kidney disease? Any specific age groups or certain um, uh, activity levels or lifestyle?
So what can you think of? Primarily, what would be our at-risk population be? What comes to your mind?
Mostly like around the age of 60.
That could be right. And what's happening in terms of disease processes, let's say, we know our prevalent disease in the United States. So diabetes, number one, high blood pressure, number two, metabolic syndrome could be another factor, right? Yes, this process starts way early in life, maybe in your 30s or maybe in your 40s or maybe even earlier, right? But it starts to present when you're late in your 50s or 60s. So our general population who's a classic diabetes 2 person with high blood pressure, kind of uncontrolled, maybe at some point was poorly controlled and now well controlled, whatever. But yeah, that would be my target patient population for the most part. So that's the at-risk population. diabetes becomes, remains uncontrolled, and eventually we start to see proteinuria. And that's our first sign where, we see subtle signs even before a decrease in GFR. Proteinuria starts to happen, microalbuminuria. They're dumping less than 300 milligrams per gram of protein, right, in the urine. We see very subtle signs. So that tells me that, hey, the glomerular, the GM is going down, right? There's some damage happening at the molecular level. They start to dump out proteins, and that's a red flag. So we try to intervene as early as possible with the use of medications. ACE inhibitors, first choice, ACEs, ARBs, all these others, SGLT2 inhibitors becoming more common, of course, and that has shown tremendous improvement. I mean, in preventing progression of kidney disease.
Thank you for that answer, Dr. Khan. The second question is, what is the current area of research of interest regarding the kidneys now?
Artificial kidney. So that is a current research, I mean, if it turns out to be a successful thing, then of course, the burden we have on due to dialysis populations and end-stage renal disease is going to go significantly down. So the idea before artificial kidneys was to, do as much transplants as possible. Because burden of health, end-stage renal disease on healthcare is significant. So in order to reduce that, there has to be some other outbreak. So they're working on it. It's a bovine kidney, I think, transplant, artificial kidney. So let's see. I mean, if it turns out to be a successful venture within, hopefully, the next couple of years.
Thank you for that one. Another question that I personally had during the lectures was why physiologically is the proximal convoluted tubule tasked with water reabsorption while distal is not.
So that's how it is. Your reabsorption has to happen at the proximal tubule, right? And why water? Because of the osmolarity gradient. So sodium, wherever sodium goes, water kind of follows it. So that's primarily how and why. So our 2/3 portion gets active reabsorption happening at that level. Whatever is left off, of course, And yes, that's an excellent question, because what do you think would affect secretion primarily at the distal convoluted part of the tubule? There's another important step that I didn't mention in my slides, or we didn't talk about or touch base on, is the juxtamedullary apparatus, where distal convoluted tubule is in very close proximity to the glomerulus. And around the glomerulus is where our juxtamedullary apparatus is, macula densa. Basically, these are the chemoreceptors or osmoreceptors there. They can actually perceive that state, right? So the chemoreceptors or the osmoreceptors, they can actually gauge the absorption or the secretion of the distal part. And that's how it's closed, and that's how it's kind of managing or micromanaging your major part of the nephron. So that's an excellent question.
Thank you. So another question that I had was, you touched on the use of creatine in one of your slides. I was wondering or curious about the recommended length of creatine use for certain individuals, such as like athletes versus the regular population.
So yes, in our clinical practice, we see it quite often now, right? A muscular guy who works out, he has heavy muscle mass, and he comes in and he says, hey, I work out excessively, I take creatine powder, my creatine's been off, it's been out of whack, what's happening? Is my kidneys going down? First question comes to my mind, is it actual an underestimation of GFR, rather, because of the high creatinine, right? That's being being produced by the muscle, and which is kind of throwing him off and his miscalculating his GFR. So that's when our cystatin C comes into play. I mean, for all practical purposes, inulin at bigger centers, at academic units, yes, inulin clearance can be measured, is being done. But I guess for us, my next alternative is just to check irrespective of their creatinine. Of course, if their cystatin level comes back abnormal, that's the problem. But if that comes back with a normal GFR, then I kind of reassure patients that, hey, it's probably all because of your heavy muscle mass, as compared to you. If there's a thin lady who's coming in, she essentially doesn't have any muscle on her, and we are calculating her creatinine, and that tends to be low, that's kind of overestimating her GFR. In reality, it might be lower than actual.
Thank you.
All right.
The question is, how important is the connection of the brain to the kidney?
How important is the connection?
Yes.
That connection is in what sense, in what terms?
And I guess regulation of the kidney's functions.
Mm-hmm. Well, see, in terms of regulation of certain specific electrolytes, we can say, the brain has the connection. Sodium per se, right? If you have a hyponatremia patient, let's say sodium is down below 120, right? What effects are happening in the brain to kind of counterbalance that effect is that's where your ADH comes into play. That's where your V2 receptors come into play. So in order to conserve your sodium, more of the ADH release is going to go down. Aquaporin level, V2 receptors, it's going to go down. Hopefully, less water gets reabsorbed, and that's kind of maintains the homeostasis. So at many levels, many hormones can get secreted out. Now, I didn't talk about one essential hormone which the kidneys, produce, is erythropoietin. Of course, we'll talk about that when we talk about a little bit about anemia, but that's essentially another hormone which gets produced by the kidneys, and people who have renal failure, they tend to have anemia, and that's because of low production of erythropoietin. So renin is one hormone, erythropoietin being another hormone. It works with ADH. Yep.
Thank you so
So
much.
let me throw in a scenario, and that's, I guess, another important question which they can and always ask is is a runner, a marathon runner, who's been running and drinking water, consuming loads and loads of water. So what's going to happen? And he passes out, like all of a sudden collapse. So what happened to that patient? Let's talk about sodium. In terms of sodium, what happened to the sodium level?
Uh, maybe there was a storage of sodium that wasn't being released into the body or being overly stored.
So I think, yeah, Beanish answered hyponatremia. Excellent, Beanish. So yes, hyponatremia. Someone's running, water is being, they're dehydrated, they're sweating, they're chugging in water, and it's primarily just water, no electrolytes in it, right? So sodium's going to drop down acutely. There's going to be a sudden drop in sodium levels, and that's why patients, or I mean, these athletes, they tend to collapse or pass out. In an acute setup, of course, what we need to do is we just want to give them some salt so that sodium level gets better. But that's the whole idea behind it, and that's a popular question. I remember it from back in the days. I guess they always used to ask me about a marathon runner, drinking water, so hyponatremia, and the whole ADH axis.
Thank you. And one final question is, what is something everyone should do to prevent, to protect their kidneys?
Everyone do. Okay, well that's so many things, of course. I mean, and it's the answer can be I can given in in a different fashion, maybe, I guess. Common things. Let's say, yeah, okay. Let's talk about non-steroidal drugs. Someone having migraines, an elderly lady, I would say, or a lady in her 50s. She has a higher, maintenance lifestyle. Maybe throw in some corporate job. So she's anxious, she has migraines are happening all the time. Okay, well, what happens to the migraines? Well, nothing works for me, doc. It's just the Excedrin. I take 3 Excedrins a day. And that's a very common scenario. People come in with all sorts of pain problems. Non-steroidal seems to be the key, is the answer, because of its anti-inflammatory properties. It's the way it works better than quote-unquote Tylenol. People tend to take it judiciously. So our non-steroidal drugs for kidneys, it's a problem, right? And that's been a very, very common scenario. People come in, many years of non-steroidal use, and now they have kidney damage or kidney problems, or even acute kidney injuries with heavy uses of nonsteroidals. So that's one potential that we try to kind of educate more in our clinical setup, not to use nonsteroidals unnecessarily, judiciously, because of course, even for a normal person with heavy use, we do see a decline in kidney function. And that's our whole efferent arteriolar pathway, decreasing constriction, causing vasoconstriction, and the prostaglandin pathway. So that's one lifestyle change, of course, staying well hydrated, drinking according to your thirst. If your thirst in the brain is intact, you don't have to chug in large quantities of water. The idea they used to say, hey, 12 glasses of water a day. That's not normal. So what we tell our patients, hey, if you're not thirsty, don't drink. If you're thirsty, go ahead and drink. Besides that, for renal disease, of course, it's the disease burden, better blood pressure control, better lifestyle changes, better choices in food, less salt intake, less or balanced animal proteins, balanced meat. These are all essential because with more meat comes more problems. High uric acid, it's the salt burden, it's more, volume related problems. So yeah.
Okay. That was my last question. Thank you very
Okay.
much for your time.
All right. Well, thank you so much, guys. I hope you benefit out of this little talk today. But yeah, it was a pleasure to do this.
Yeah. If everyone could give a warm thank you to Dr. Khan in the chat box for this informative session. Thank you.
Thank you, guys. Thank you very much. All the best to all of you.
This is our quiz with our future session dates. The link to the session is now live. You will need a 70% or higher to pass and receive the certification. Now on to the next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, September 16th at 10 a.m. Eastern Standard Short Time for another nephrology session. Thank you so much for everyone for attending today's session. We hope to see you in upcoming sessions. This concludes this week's shadowing session. Thank you.